My name is Dr. Jeffrey Juma. I'm the District Medical Officer for Mangochi District, and I have been here for just over 1 year, and have been here since the entire time that AMREF has been present in our district. And within the DHMT, as regards to AMREF, I'm the AMREF focal person, so all the activities that are under AMREF are coordinated through me. And for example, the VVF is just one of the projects that we're coordinating. So in terms of all the assistance that the district hospital puts into this project for the mobilization and so on and so forth, all that is done via this office, liaising with the district health officers. Before AMREF came in, Mangochi was one of the impact areas which we have a high number of VVFs in the country for various reasons, and in the past there would be these big camps at Queen Elizabeth Central Hospital, and we'd be required to send our patients there so that the VVFs are repaired. Yes, it worked, but it also had a lot of challenges in terms of logistics from the patient's point of view all the way to us, as well as for those at Queens. And AMREF was able to come in and help us with all sorts of equipment and drugs, ranging from blood pressure machines all the way to certain drugs like benzyl penicillin as well as magnesium sulfate to help our pregnant women here in Mangochi. So right off the bat, AMREF showed a great commitment by both pledging and almost immediately procuring these things for the district. In my opinion, the biggest impact that AMREF has helped with is the VVFs. This is a vesical vaginal fistula surgery that we're doing within the district. As much as the overwhelming support that the community has brought forward and case identification, as much as that is a success, it has also proved to be quite challenging, because to turn a patient back when we're overwhelmed with capacity also presents that. I think out of all the challenges, that's the biggest challenge. I think as Mangochi DHO and as AMREF, we underestimated how much the community actually respond to this. So we're victims of our own success. I think the mobilization was very, very good. And as more successes come in with the previous camp, where a lot of people are now living better quality of lives, they are providing to be our focal person and our spokespersons in the community as well. Some of these challenges, especially the biggest focus being on the patients themselves, was that most of the women did not feel that going all the way to Blantyre from here would benefit them, because the surgeries, post-surgery, they have to be in hospital for up to about 2 weeks. As a whole, they're away from home from between 21 days to 28 days. And for majority of them, they're mothers, they have children to look after, and so on and so forth. So the feeling of leaving home and going far away for close to a month presented a huge challenge, and the recruitment was not as great as we would have appreciated as a hospital, knowing the burden that we have out there. So when AMREF came in with this idea of local capacity building, it was pretty much welcome. And to date, so once this has gotten off the ground, as can be attested by everyone in the community, the number of patients coming in has actually been overwhelming. And we honestly did not think that this response would be as great as it was. And this, in part, mainly is due to AMREF willing to help the local capacity building of Mangochi. They've trained a few people who have gone, fistula nurses to be trained, some clinicians also who've gone to be trained in doing fistula surgeries. And we appreciate that AMREF will always be in the district, but they want to make a lasting impression that when they leave, the capacity building will still stay strong, will still be doing these things, and that their effect will be long past the time that they're with us in the district. On top of the fistula surgeries, all the logistics that have improved, all the patient outcomes. We've had the two camps so far with overwhelming success. I think everyone, if you go to the communities, will attest to the overwhelming success, not just on the surgery side, but on the socio-economic side as well. They've involved social welfare, who have come in and have taught these women business traits, how to do certain things, knitting, craft creation, different types of cooking, and so on and so forth. And those women have been able to go out into the community and improve their life, not just because they no longer have the fistulas, but because now they're able to stand on their own 2 feet. And this is something that, as a district hospital, we are very proud of, to be in this partnership with AMREF, because our patients and our mothers are really benefiting from this partnership. Beyond the scope of the VVFs, we also have trainings and supervisions that AMREF is helping us with. In terms of DHMT supervisions, they are helping us with those. We'll be able to go out into the various facilities and identify problems and get to the root causes and identify solutions with the help of AMREF, as well as the people from the health centers. And that too has been quite a success, and it's still ongoing. They're still helping us with that. On top of DHMT supervisions, we also have pharmacy supervision, where AMREF has come in and actually helped as well with the pharmacy supervisions, so that our drugstores are better managed and we have greater drug availability for the patients that we're serving in this community. On top of that, we also have AMREF coming in with some HSA trainings for the drugstore clerks. This as well should be done in this quarter, where they're going to help our drugstore clerks get a refresher, so that they realize the burden that we're having with mismanagement of pharmaceuticals. And this is just one of the measures that AMREF has put in to help us with such things. For the cost of surgeries within the district, we've identified our sister hospital, East Monkey Bay Community Hospital, to be the site where we do these operations. And the logistical management of it, the majority of the cost burden has been AMREF. DHO comes in providing clinicians and nurses, as well as providing vehicles for the mobilization. But the majority of the cost burden, such as fuel, feeding of the patients, and calling in of the specialists to come and help us with the VVFs, the burden of that majority is on AMREF as an organization. For the sustainability of the VVF surgeries, AMREF has come in and helped us. We've identified one clinician who went to the big camp at Queen's and was taught by the specialists from Kenya and the one specialist we have in Malawi on simple VVF surgeries. So this person has been active ever since, in terms of from the mobilization of patients all the way up to the surgeries. And whenever we have a camp here, he takes a lead in arranging everything and is actually assisting with the surgeries. So he's getting on-the-job training, and so small simple cases he's actually able to do now. And with the more camps that we have within Mangochi, his skills and the scope of practice is increasing. Not just on the surgeon side of things, but also for the nurses. The VVF nurses, we have a mentorship program where the nurses from Queens have come in previous camps and trained the nurses that we have within the district on all the various things that they need to do as a theatre nurse for VVF surgeries. And the knock-on effect is that within the mentorship program of the district, these people who are being trained are also training others below them. So even post-AMREF, we expect that as Mangochi District Hospital, we will have the people with the capability to do VVF surgeries, as well as all the things that surround VVFs. All the problems really were to do with the service delivery and nothing else. So that's an interesting challenge, all the problem solving. I think AMREF has learned a lot from Mangochi DHO, and Mangochi DHO has also learned a lot from AMREF. So an issue of comparing notes and finding amicable solutions to a lot of problems has been the way that Mangochi has worked with AMREF. For other things, we look towards our traditional leaders and the chiefs and so on in the areas. So when they go for the mobilization, I think it's a entire community involvement, and we look for the local leaders within the community to help with identification as well as advocacy in terms of everything that surrounds VVFs, in terms of social stigmas and so on and so forth. So the social stigmas, the case identification, and the attitude of the community towards these women once they come back. So the social welfare, as well as AMREF and the DHO, in terms of our public relations officer, go out into the community, and they give these talks, health talks, and so on and so forth, to help with the social aspect of things, while our women are also being helped on the social aspect of things in the hospital.